So my name is Dr. Stephen Holt. I'm an addiction medicine specialist and general internist. I work in New Haven, Connecticut, where I direct the addiction recovery clinic embedded at Yale School of Medicine. Disulfiram is the oldest medication for alcohol use disorder that we have available that's FDA approved. It's been around since the 1950s. And ultimately what it is an inhibitor of an enzymatic reaction that's involved in the metabolism of alcohol. So when you consume alcohol, it's broken down into acetaldehyde, and then acetaldehyde is broken down into acetic acid. Disulfiram blocks the second step in that enzymatic pathway. And in that sense, ultimately serves as a deterrent because it's really unpleasant to have that molecule, acetaldehyde, lingering in your body. In general, the most common side effect of disulfiram is aptly named the disulfiram reaction. And it's essentially the idea that when you consume alcohol, since you're unable to metabolize it effectively, this metabolite, acetaldehyde, accumulates in your body and causes a host of really unpleasant side effects. It's sort of like experiencing the worst hangover of your life, but all over the span of several hours immediately after drinking. That could include flushing, palpitations, anxiety, tremulousness, certainly nausea, and vomiting wouldn't be unusual. So all these really unpleasant effects. And that's essentially the disulfiram reaction, which would only occur after you consume alcohol in the presence of disulfiram. In addition, even the drug itself, even in the absence of alcohol, is associated with some side effects, most of them mild. So there is a potential increased risk of neuropathy. There's an increased risk of hepatitis or, elevation in liver function tests. There are potential cardiac manifestations. And those are the primary ones that we think of.
I should also mention some important contraindications to the use of disulfiram. We already know that disulfiram is not appropriate for folks whose treatment goal is anything other than abstinence. But in addition, disulfiram is contraindicated for patients with decompensated liver disease, specifically Child-Pugh Class C cirrhosis. We would also avoid its use in those with acute alcohol-related hepatitis, patients with significant coronary artery disease, and those with a history of psychosis.
The efficacy for disulfiram has been best demonstrated in patients who have some degree of a support system. So most medications, you just prescribe it and you trust the patient will hopefully take it. With disulfiram, there's a lot of evidence that supervised disulfiram is really the way to go. And what does supervised mean? It doesn't mean that you have to be in a controlled setting. It doesn't mean that you have to have, a parole officer looking over your shoulder. It just means that you have to have a friend or family member helping to promote self-administration of the medication. So the best patients really for disulfiram are going to be those who do have an invested friend or family member who's willing to sort of promote adherence to the medication. In addition, by virtue of the way the drug works, it has to be someone whose motive or whose goal is abstinence, right? You can't use this medication to cut back on your drinking. It's an all or nothing kind of drug. As soon as you start taking this drug, alcohol really has to be off the menu. So it's not for folks just looking to cut back. One of the most important considerations is to understand the efficacy of disulfiram. There's been sort of a bias against disulfiram for decades, and a lot of it is based on a faulty interpretation of the literature, and in particular, a misguided approach to studying disulfiram. The simplest way to say it is when you think about trying to study disulfiram, if you do a double-blinded, randomized controlled trial where you offer some patients disulfiram and other patients a placebo, and the patients don't know which one they're getting, both of those patients are going to be very motivated to not drink alcohol, right? Because they don't know which, it's sort of like which chamber of the gun has the bullet in Russian roulette. So you're not going to pull the trigger at all. You're not going to drink alcohol. So the problem when you do those kinds of double-blinded randomized controlled trials, you're diluting the potential effect of disulfiram relative to a placebo because of this drug's unique mechanism of action. subsequent studies that have looked exclusively at open labeled randomized controlled trials have found that when patients know that they're getting disulfiram, as opposed to knowing that they are not getting disulfiram, there's actually dramatic evidence of efficacy for supervised disulfiram relative to placebo and even relative to many other, well, all the other FDA-approved medications that we use, namely naltrexone and acamprosate. So my message in general is that disulfiram has been, I think, given unfair treatment by guidelines and many other folks in the field. When in reality, it's a very effective medication, especially when used in supervised settings. And the safety data is also quite good. Again, this medication's been around since the 50s, so it's not like some new drug that we don't have a lot of experience with. So again, this is a very effective medicine. It's very safe. I think I would really get in the habit of, when you're seeing a patient, whether it's in the hospital or in clinic, really make sure that you don't immediately go towards naltrexone or acamprosate. Find out if the patient actually has a support system. If this patient's goal is abstinence, and if they have a partner who's frustrated with their drinking, if they have a close friend or a roommate that they live with who's willing to be a partner in this person's recovery, use that person, ally with that person. And you'll find that patients will do remarkably well when they have somebody who's a partner in their treatment team. The last point I would make about that is there's some evidence that you don't want that relationship between the supervisor and the patient to be this adversarial, monitoring type thing. Again, like having a parole officer looking over your shoulder. Instead, it should be a collaborative effort, acknowledging that the patient should be grateful that this friend is involved in their recovery and is supporting them. And the friend should be grateful that their loved one, their friend, is taking their recovery seriously. And when you embrace this kind of knowledge of, or this approach of shared gratitude, there's really an impressive amount of data showing that disulfiram can be one of the first line, most effective treatments for alcohol use disorder.